Great. Hi, everyone. We'll just give a few more minutes for some more people joining.
There we go. And I don't have to join shortly.
Hello.
Hi, everyone. Hi. All right. Okay. I'm going to get started here as some more people trickle in, but I'd like to say hello to everyone. My name is Kelsey. I am the LTCI operations lead. Please feel free to introduce yourself in the chat. We'd love to hear who you are and your role and where you work would be great. I want to take a moment to welcome you all to the LTCI Learning Series on wounds. It's with great respect and appreciation that I'm speaking to you today from the traditional ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations that I am fortunate to reside on. Just before we get started, I want to run through some housekeeping items. Please, if everyone could just mute their mics so that we don't have any background noise during the presentation. So if everyone can just double check and make sure that you're muted, that would be great. This is a CME credit event, and they'll be available after this event. A member of our LTCI team will email you your certificate in the coming days. At the end of the event, we also have an evaluation, and we would love for you to be able to fill that out. We love hearing your feedback, and it helps us make these events better and better each time we do them. This event is recorded and posted on our website, and the slides that are up today will also you'll be able to get a copy if you'd like. If anyone has questions during the event, please feel free to unmute yourself and ask away. We love for these learning series to be as interactive as possible. And at the end, there will also be a chunk of time to have questions and a bit of a dialogue there. Okay, without further ado, I'd like to introduce our presenter, Erin Ballard, NSWOC Erin. Erin grew up on Vancouver Island and has been nursing since 2009. She began her career as an LPN in acute care, working with postoperative patients, and then completed her nursing degree in 2018 and continued to work in acute care in areas of oncology and palliative care. Her interest and experience in wound care led her to complete a nursing specialty in 2021, and she is now a nurse specialized in wounds, ostomy, and continence. She moved from acute care to long-term care in 2022 and is now the NSWOC for Affiliate and Island Health long-term care homes in the Center and North Island. So without further ado, I'm going to hand it over to Erin.
Okay, thanks, Kelsey. And it's nice to see you all this evening. I'm Erin, and I'm just going to share my screen and we'll get going on the presentation. There should be lots of time at the end for questions, so feel free to put your questions in the chat or save them till the end. Yeah, happy to take any questions at the end about wounds or more specifically about wound infection, which is what we're going to be talking about tonight. Okay. So I have no conflicts of interest to declare. My position is as clinical practice educator with Island Health. And a couple other committees that I sit on are on the screen there.
No, it is good. I can see post-bariatric support group.
So tonight we're going to talk about infection and chronic wounds. You're going to learn how to assess for increased risk, how to recognize and diagnose wound infection, when to order a CNS swab, what local wound care practices can help prevent or stop an infection before it progresses, and when and how to use systemic and topical treatments. We're then going to focus on two specific types of wounds that require more unique care and prevention, and those are diabetic wounds and moisture-associated skin breakdown. And then lastly, I'm going to talk very briefly about the diagnosis and treatment of osteomyelitis. So there's lots of exciting stuff to talk about, so we're going to get going. I chose to speak tonight specifically about wound infection because it comes up so frequently in our practice and it negatively impacts the quality of life for our residents. Wound infection causes pain, an increased burden of wound care for our residents, increased time spent by clinical staff engaged in wound care, an unpleasant odor that our residents have to contend with, an increased risk of hospitalization, and also an increase in the cost of care in products, medications, clinical staff time. Wound infection also, of course, impacts how wounds heal. And the chart on the right illustrates how wound infection stalls healing time quite significantly, with 41% of wounds being set back an entire month in healing time when infection occurs. So as long-term care clinicians, we really all need to be proactive in preventing wound infection and the negative impacts that wound infection causes for our residents. So step one in prevention is really recognizing the risk. Identifying those at increased risk is going to alert us to be more vigilant in assessing and then more responsive in treating an infection before it progresses. So knowing the etiology of the wound is going to give us clues to the risk of infection. Chronic wounds are at higher risk of infection, and the most common types of chronic wounds are pressure injuries, venous ulcers, arterial wounds, and diabetic wounds. And we know that these are the wounds that we most often see in long-term care. I'm sure all of you have seen these wounds. And chronic wounds are those that have not healed according to the normal wound healing trajectory, and they've been present longer than 4 weeks. So that's our standard definition of a chronic wound is one that's been there longer than 4 weeks. Next up in our assessment, we're going to assess factors that impair tissue perfusion to that wound, such as smoking, hypertension, COPD. Because without adequate perfusion, the wound is not going to have the benefit of a really robust host immune response to bacteria. Next, you're going to look for any underlying factors that will increase the infection risk. That being, for example, incontinence, advanced age, certainly that is our population, nutritional compromise, and suboptimal personal hygiene. All of these things are going to increase the bacteria that's living around that wound. And then we're going to identify any medications that are going to impair the immune response. This would be corticosteroids or methotrexate, for example. And then ask yourself what comorbidities are present that are going to put the resident at risk of infections, such as diabetes, cancer, any autoimmune disease. And then lastly, have a look at the wound itself. Wounds that are large, long-standing, those chronic wounds that have been around a while, wounds that are sloughy, or if we have wounds in the sacral or perineal area, or wounds that have bone or tendon exposure. All these factors are going to increase the risk of infection for your wound. So when you put all these assessment pieces together, you're going to be able to see who in your practice is at higher risk of developing a wound infection. So wound infection occurs from both the natural bacterial flora that resides on our skin and from outside sources such as contaminated gloves. Infection develops with the presence of these microbes in sufficient numbers or virulence coupled with the resident's inability to resist infection, and based on all those risk factors that we just discussed on the last slide. So we know that all wounds contain bacteria. But this doesn't mean that all wounds are infected. Wounds can be in bacterial balance or bacterial imbalance. So when a wound is contaminated or colonized with bacteria, it still remains generally in bacterial balance, and it can still heal. And we've seen wounds heal because, like I said, all wounds have bacteria, but that doesn't mean that this bacteria is preventing wounds from healing. We see lots of wounds heal. So those that are contaminated or colonized, they can still heal, allowing for, other variables, of course. But it's really only when we get to local spreading and systemic infection, that's when we start to see the wound fail to progress, fail to heal. So a local infection occurs when the infection is contained within the wound itself. And then as the infection progresses, it spreads beyond the wound border and it invades the tissues surrounding the wound. And this is when we see a spreading infection. And then you see there on the continuum between colonization and local infection is where biofilm becomes a significant factor in our wound healing or our stalled wound healing. So biofilm is a driver of recurrent infections and it stalls that wound healing. So we're going to talk a little bit about biofilm. So biofilm is an invisible thin layer of polymicrobial bacteria. It began its life as planktonic free-floating bacteria in the wound, but because they've been in there a while, they then attach themselves to the wound bed and they cover themselves in a protective barrier that they secrete from themselves. So they've covered themselves in this barrier, and underneath that barrier, they get together, they have babies, they multiply, they create little families under there. And that filmy barrier, it really serves as a protection for the bacteria from the resident's immune response. It also protects against many topical antimicrobials, and it protects against systemic antibiotics. Biofilm can also live in slough, eschar, and dressing materials. And 60 to 90% of chronic wounds have biofilm. And that's in contrast with only 6% of acute wounds. So chronic wounds, biofilm is a significant factor in non-healing chronic wounds. CNS swabs cannot detect biofilm bacteria, and biofilms cannot be treated with antibiotics. And biofilm bacteria causes recurrent wound infections that are hard to treat and prevents those wounds from healing. It stops wound healing by impairing the growth of new tissue and keeping that wound in a perpetual state of inflammation. So we can help prevent biofilm from progressing by using effective and regular wound cleansing. This will really a good, thorough, regular wound scrubbing, for lack of a better word, is going to stop these free-floating bacteria from settling down into biofilm. As well as good wound hygiene, choosing the right dressing for adequate exudate absorption and management is important because biofilm easily forms and thrives when there's pooling of exudate on the wound surface. So there are wounds that we have seen in our practice that tell you quite loud and clear that they're infected. But there are other wounds that are a bit more subtle with their communication. Whether this is due to compromised immune response or darker skin tones that do not present with the same color of erythema, there's always going to be wounds where we question whether or not they're infected. So we know that a diagnosis of wound infection can be challenging. So how do we know if a wound is colonized or if a wound is infected? How do we know if it's a local infection versus a spreading infection, and what's the difference there? So let's talk about that. So a standardized approach to what we assess and what that assessment tells us is the best way to diagnose a wound infection. I have a standard set of questions that I ask the clinical staff when I'm assessing for infection, and then I diagnose based on what that assessment is telling me. So for a local infection, these wound infections present with, firstly, stalled healing. So if you have a wound that's been healing nicely, and you know that because the measurements of that wound are getting smaller, the edges are slowly creeping in, the depth of the wound is getting shallower, so it's doing nicely. These are the wounds I like to see. And so it's coming along, and then all of a sudden you notice that it stopped coming along. The measurements are remaining the same when you do your wound assessment. So that's one sign of a local infection, is when that healing stalls. Another is friable bleeding wound tissue. This could be hypergranulation tissue, usually. And so if you've got an easily bleeding wound where you didn't have one before, that's another sign of a local infection. if there's an increase in wound exudate, and this doesn't have to be purulent wound exudate. If you've got a dressing that you've been changing regularly, it's been working well, you're changing it, let's say, every 3 days, and then you come back the next day after you've done your dressing change and you notice that dressing is saturated. So all of a sudden your wound has started having increased exudate, then that's another sign of local wound infection. And like I said, that could just be serous exudate. It doesn't have to be purulent. Certainly increased pain is another sign of infection, a local infection. And then if you have a malodor to that wound, then that's another sign. Whereas on the other hand, spreading infections look a bit different. So spreading infections present with that erythema and induration. So you have some edema, swelling right around the wound. You've got that bright red color for those with lighter skin tones. And this erythema and induration extends beyond about 2 centimeters of the peri wound. That's one certain sign that, like I was showing you on that slide a couple slides ago, that's certainly a sign of a spreading infection. And then increased wound size. So these wounds aren't just stalled, but they're actually getting bigger. If there's any satellite wounds that show up in the peri wound, this is a classic sign of a spreading infection. So new spontaneous wounds popping up in the peri wound. And resident lethargy and loss of appetite is another sign of a spreading infection. And then for a positive diagnosis of either local or spreading, I'm looking for 3 or more of these signs or symptoms from either column. And then for a person with diabetes, I'm looking for 2 or more positive signs because they have that blunted immune response and higher risk, which we'll be talking about a little bit later. And when you're doing either doing your assessment or talking with the clinical staff about their assessment, I always try and be as specific as I can when I'm asking them questions. So for example, when I ask the staff, if there's any wound malodor, I make sure that I ask if there's any odor after the wound has been cleaned. Because there's always, pretty much almost always going to be an odor from an old dressing. But that doesn't mean that there's an infection going on. That's just old dressing smell. Or, for example, you may know that I connect with the clinical staff virtually. So I have a virtual practice. So I can see the staff on video when they're doing their assessment. So if I ask them about a malodor and I see the nurse lean way in towards that wound, then I am pretty reassured that we don't have an infection going on, because you shouldn't have to get that close to a wound to detect the odor. You'll be able to notice that malodor after you clean the wound without getting right up nice and close to it. So our job at this stage is to really effectively assess wounds at every dressing change for those signs and symptoms of an infection. And our hope is that we can stop a local infection before it progresses to a spreading infection. So if a diagnosis of spreading wound infection has been made, our usual next step is to get some antibiotics on board. But before we do that, we really want to know what bacteria is causing the infection. And this is where our culture and sensitivity swabs come into play. So a CNS swab provides information on the type and the amount of microorganisms present in the wound and the susceptibility of that microorganism to specific antibiotics. And really unclear guidelines on when to obtain swabs really results in random CNS swabs being taken. However, wounds should really only be cultured when signs and symptoms of a spreading infection are present. And this is why that standardized approach to wound infection diagnosis is so important. So a spreading wound infection occurs in the viable wound tissue, and therefore viable wound tissue must be swabbed. We don't want to be swabbing any necrotic tissue in the wound. And if you have a wound that's covered in necrotic tissue, it will need to be debrided before it can be swabbed. And we also don't want to be culturing wound exudate. So we don't culture purulence as well. So to take an effective swab, you want to choose that pink or red area about 1 centimeter square, and then take your swab and hold it at a 90-degree angle to the wound, like in the photo there. And we want to push that swab down quite firmly. And when I say firmly, it really should be a little bit, unfortunately, uncomfortable for our residents. Because what we're trying to do what we're looking for when we are taking a swab is to push down firmly enough so that we're expressing the fluid from the deeper tissues, because this is where the wound infection is occurring. So this is where we want to take that sample from. We know that there's plenty of bacteria that's living on the surface of the wound, on the any necrotic tissue that's in the wound, but this is not the bacteria that's necessarily causing that deeper spreading infection in the tissues. So this is why we take the wound swab in this method. And always remember to clean the wound first before you take a swab, always. And if you use wound cleansers in your practice, this would be the time to put those away, because we always want to make sure that we clean our wounds with normal saline only before we take our wound culture. So there are some bacteria that are more common in the wounds that we see in long-term care. And by those wounds, I mean chronic wounds. So acute infections present mainly as gram-positive microorganisms, and Staph aureus is a primary agent here. In chronic wounds, gram-negative microorganisms are the majority. However, chronic wound infections are almost always polymicrobial, so we often see a mix of several different bacteria in our wounds that's causing these wound infections. So I've put 4 of the most common on the screen here, and Staph aureus is probably our most common. So Staph aureus is a common type of aerobic bacteria that lives on the skin and the mucous membranes, and it's only able to invade via broken skin or broken mucous membranes. Therefore, our biggest win that we can have in combating Staph aureus is really to preserve our residents' intact skin. Of course, that's what we're always looking to do, but this is going to help us in our fight against Staph aureus, is preventing any skin breakdown. E. coli is an anaerobic bacteria that lives in our digestive tract. And we usually see this bacteria later in the course of wound deterioration and also in deeper wounds. Pseudomonas is a common bacteria. I know we've all seen Pseudomonas in our practice. It usually also occurs later in the course of wound deterioration. It's also commonly found in diabetic foot ulcers, and this bacteria you may recognize because it presents with that green tinged wound exudate. So if you have a wound, you take the dressing off and you notice a green tinged exudate, it's most likely due to Pseudomonas. And then lastly, Proteus mirabilis is found. This bacteria is found in multiple environments. It's in long-term care facilities, it's in hospitals. It's not unusual for Proteus to colonize both the skin and oral mucosa. And wound infection really primarily occurs from these reservoirs. So the options for local wound care and dressing selection, as we know, is rather vast, and we're not going to go into dressing options tonight, or we would be here for a very long time. Nursing certainly knows to come to myself or the South Island and Swat Shelley Barnes with any advice needed on dressing selection. We're here to help with that for sure. But there are some general wound care principles that will reduce our residents' risk of wound infection. And I mentioned that first one before, but I'm going to mention it again because it's so important. That regular, thorough wound cleansing. And that includes cleaning the peri-wound because of that normal bacterial flora that lives on our skin. That can easily just sneak into that wound if we're not cleaning that peri-wound. It can boop right in there. No problem at all. So Wound cleansing will also help prevent that free-floating planktonic bacteria from settling down into biofilm. And it also helps, it's also really crucial in preventing necrotic tissue from building up. And bacteria lives and feeds off of necrotic tissue in the wound bed. They love that stuff. It's their favorite meal. So debridement is also important. Safe debridement of the slough in wounds it will also help in preventing wound infection. Of course, there are wounds that we don't want to aggressively debride, such as malignant or arterial, like non-healable arterial wounds. But for those wounds that are healable, that we're healing, debridement is important. And then ensuring exudate doesn't pool on the wound bed by using that right dressing that's going to help prevent slough from building up and also prevent the peri-wound from breaking down and allowing bacteria into the wound. And as we talked about earlier, assessing the wound for infection at every dressing change. So we can stop that local infection if there is one. We can stop it from progressing into a spreading infection. And we do that by utilizing our topical antimicrobial dressings. And then lastly, I don't suppose it can ever be said enough, but hand washing and aseptic technique with wound care is of course important. So I want to talk a little bit about the use of topical antibiotic ointments. We do see these used a lot in long-term care, so I thought I'd touch on them. So topical antibiotic ointments can be helpful for like minor scrapes and cuts, but they're really not recommended for more complex chronic wounds for several reasons. Firstly, the ointment adds moisture to wounds, and these wounds generally don't need any added moisture. They're either already too wet, or we're trying to keep them dry because they're non-healable arterial wounds, for example. Secondly, the ointments need to be applied daily or BID to really ensure their sustained effect. And it's not ideal, of course, to have wound care done once a day, and sometimes it's not even feasible. But as well, every time we remove a dressing from a wound, the temperature of that wound drops by several degrees. And this sets back the healing time of the wound by an average of 6 hours. So every time you take a dressing off, that temperature drops and you're setting your healing time backward. And so if you're doing daily dressings, that's a huge loss in healing time. So we have dressings designed to create that perfect moist wound environment and that perfect temperature for wound healing. Thirdly, the antibiotic in the ointment also has a single defined microbial target, which really limits their effectiveness against multiple pathogens. And as we learned earlier, chronic wound infections are primarily polymicrobial. And then lastly, ingredients in these ointments contain sensitizing agents, and they can cause skin reactions over time, especially in our population in long-term care. So although a recent meta-analysis by Zhang et al. Showed lower wound infections with the use of topical antibiotics over placebo or antiseptics, this study was in prevention and treatment of uncomplicated wounds. And given the nature of our wounds in long-term care, the complicated nature of our wounds in long-term care, I don't recommend topical antibiotic ointments or creams generally. Not all the time, but generally. And instead, what I recommend is to try antimicrobial dressings that include any of those ingredients listed on the screen there. We've got lots of options to choose from. They, of course, all do different things, but that's another presentation. But we've got silver, iodine, honey, PHMB, methylene blue, gentian violet. So lots of dressings that have those in them. And the reason I recommend these is that they provide sustained antimicrobial activity, and they don't require daily dressing changes. They also don't induce antimicrobial resistance, and they provide that nice, moist wound healing environment that we want. for a lot of wounds, the more we can leave it alone and allow it to heal, the better it's going to do. So we've talked a lot so far about bacterial wound infection, but another source of skin infections is fungus, and topical fungal skin infections are unfortunately common in long-term care and are most often secondary to moisture-associated skin breakdown. So moisture damage in skin folds, this is known as intertrigo, is caused by overhydration of the skin due to a combination of trapped moisture and then the friction between those opposing skin folds. So that's just skin rubbing against skin. And that overhydrated skin drags rather than glides over opposing skin surfaces. And this leads to friction and skin damage. So intertrigo can and often does coexist with incontinence-associated dermatitis, and this, of course, makes the risk of skin breakdown and infection even greater. Intertrigo can also present as a linear skin tear at the base of a skin fold, and this tear may occur when the overhydrated skin is stretched during routine assessment and skincare. Contributing factors to intertrigo include reduced perfusion due to a higher amount of adipose tissue, diabetes, and then the use of steroids and antibiotics. Obese individuals are at higher risk of intertrigo due to the increased perspiration and the physical challenges to performing skincare in deep folds. So intertrigo starts as erythema, and then it progresses to a more severe swelling, skin loss, and when we have skin loss, then we have that potential for secondary infection. The skin is no longer serving as a barrier against infection. And bacteria and fungus thrive in this nice, lovely, moist, warm environment in skin folds. So in long-term care, we use wicking fabrics to move the moisture out of the skin fold, and they also provide treatment and prevention of fungal and bacterial infection because they contain either silver or hydrogen peroxide, and they provide a sustained release of either one of those antimicrobial agents. So this is a great product for both prevention and treatment, and I do recommend using them for prevention as well. There is also often a role for topical antifungal therapy if the wicking fabrics are not staying in place well, which unfortunately, usually there are often times where we can't keep these fabrics in place. So a variety of topical antifungal agents are used to combat fungal infections of the skin, and they can be applied twice daily for 10 to 14 days. Low-dose topical corticosteroids may also be used in combination with an antifungal as they reduce that inflammation and they help restore the normal skin barrier. Just make sure that your antifungal ointments or if you have prescribed an oral antifungal, just make sure that that treatment is continued for 7 days after the disappearance of clinical signs to prevent recurrence of that fungal infection. But again, I really strongly encourage everyone to be proactive here and prevent intertrigo by using those wicking fabrics in skin folds. Use those preventatively. Don't wait for the skin to break down before using those fabrics. Because we can treat, of course, we can always treat a fungal infection in a skin fold with those ointments, but that doesn't really fix the causative issue, right? We will heal it up, but it's going to come back unless we do something to move that moisture out of the skin fold. Okay, I want to talk now about those in our care with diabetes. Because residents with diabetes are at higher risk of wound development because of neuropathic changes to the diabetic foot, which cause impaired sensation, changes to the actual structure of the foot, causing new areas of pressure, and also dry, cracked skin. So there are things that we can do to help prevent wounds from occurring, including optimal glucose control, encouraging smoking cessation, managing hypertension and dyslipidemia. Ongoing foot and nail care aimed at maintaining skin integrity and reducing any callus is also important. Callus and long toenails can be the source of pressure wounds. Improperly fitted footwear can also be a cause of pressure wounds to the foot. So footwear should be assessed regularly. Also treating any toenail fungus that arises. And lastly, being proactive in offloading heels and other pressure points on the foot while the resident is in bed or in a chair if they're non-ambulatory. And prevention is so important for all of our folks, but for those with diabetes, it can avoid many adverse events that arise with an infected foot wound. So a recent study by Lavery et al. Compared diabetic foot wound infections with non-diabetic foot wound infections. And the results show an increase after 1 year, an increased reinfection rate in the diabetic group. See if I can get this pen to work here. Oh, apparently not. Oh, here we go. Let's use a highlighter. So reinfection rates here, 48% in the diabetic group versus 30% in the non-diabetic group. Increased readmission, hospital readmission rates for foot wounds, 47% for the diabetic group versus 29%. Increased incidence of amputation, of course, foot amputation here, 47% in the diabetic group, 43% in the non-diabetic group, and then of course, below the knee amputations and above the knee amputations, 9.5% in the diabetic group, 1.1% in the non-diabetic group. And then lastly, mortality. We have 3.1% in the diabetic group versus 0% in the non-diabetic group. So, in short, having an infected foot wound can lead to more serious outcomes for those with diabetes than those without. So looking at the amputation timeline on the left there, we can see how the diagnosis of diabetes can lead to amputation. And of course, we're looking to stop that timeline at any point. So not only does neuropathy play a part, but coexisting peripheral arterial disease heightens the risk of wound infection, while also diminishing the signs and symptoms that alert us to a wound infection. So really, not only are diabetic wounds more likely to become infected, it's harder to catch these infections in the early stages. So diabetes is the second most significant risk factor for developing peripheral arterial disease and lower extremity ulcers. The first being smoking. Well, we're not talking about that today. So not only is peripheral arterial disease more common in those with diabetes, but it's also more aggressive in the context of diabetes. Diabetes and peripheral arterial disease cause poor perfusion to the foot, leaving that foot vulnerable to infection because the body's immune response is severely limited. And visible evidence of localized infection may be muted or non-existent due to compromised arterial blood flow, also due to the blunting of the inflammatory process, and also due to diminished sensation to that foot. You're likely not going to see a lot of erythema around these wounds, and the resident may not be able to feel the pain that usually accompanies wound infection. So there are signs to be alert for, as well as our usual standardized approach from a few slides ago. There are other signs to be alert for that indicate diabetic wound infection. So this would be unexplained changes in blood glucose levels, wound deterioration, any exposed bone in the wound. If you have a diabetic foot wound with exposed bone, there's a clear sign of wound infection, or changes in behavior or level of consciousness. And then if you do have any new or worsening pain when you have someone with a diabetic foot wound and they have any new or worsening pain to that wound, clear sign, that's a clear sign of wound infection. So for our residents with diabetes for local wound care, I always advise using prophylactic antimicrobial dressings. So those 5 categories, any of those, your silvers, your iodines, use an antimicrobial dressing for residents with diabetes because they're at such increased risk of wound infection, especially for our population in long-term care because they're already so immune compromised. Many of them are already so immune compromised or compromised in other ways. So the main message I wanted to make here is to just be very alert and responsive when it comes to suspected wound infections in the diabetic population. They're at higher risk of infection and their outcomes from wound infection are poorer. And then osteomyelitis, I did say I would talk very briefly about osteomyelitis. This is certainly not an area where I am an expert, but I wanted to talk about it, especially after talking about diabetic foot wounds. So osteomyelitis is definitely a large and evolving topic. So just like local and spreading infections, diagnosis is based on clinical assessment, and then it's confirmed and supported by labs and imaging. So if you have a wound infection being treated based on swab sensitivities that you've taken, and that wound still fails to progress or it continues to show signs of infection, then I would like us to consider osteomyelitis because there is a low correlation between the bacteria found on a CNS swab and those that cause osteomyelitis. And especially if a diabetic wound probes to bone, this is highly predictive of osteomyelitis. So if we have any exposed bone in a diabetic foot wound, or we're able to feel any bone in a diabetic foot wound, it needs to be investigated for osteomyelitis if it's within our residents' goals of care. So the best place to start with your investigations is with labs and x-rays. Although an MRI is the gold standard for diagnosing osteomyelitis, x-rays can be a great place to start because you can see erosive changes indicative of osteomyelitis on an x-ray. And if we wait for an MRI, because we know that MRIs are expensive and they have long waiting lists, and they're not always accessible where our residents are. So if we wait for an MRI, then we're going to be delaying treatment and risking deterioration and worsening limb status. And then from there, of course, consult with infectious diseases, and they can assist with treatment. So treatment is usually 6 to 12 weeks of a combination of IV and PO antibiotics, or solely PO antibiotics, depending on chronicity and severity of the infection. So here we are at the last slide already. So wrapping up our talk tonight, there is a lot of information here, so please take what is meaningful for you. But there are some key points that I would like you to leave with that will help prevent and treat wound infections for our residents. So first is to recognize those at increased risk, like I talked about at the beginning. Then using that standardized approach to assessing for infection, that can bring clarity and focused treatment in the right direction. Then use your topical antimicrobial dressings to stop a local infection from progressing. And lastly, just to be more alert to wound infections with residents who have diabetes. And here we are already at the references page. And thank you. And I'm happy to take any questions that you have. And these slides will be available if you want to look more closely at any of the references. Thank you.
Hi, Erin.
Hi.
Hi. I was just wondering if you can give us a little bit of more insight into the standardized approach for the wound infections. The first, I guess that was the first point or second, I forgot in the last slide.
Okay. Yeah, let me see if I can get to that slide again. So my standardized approach, let's see, I'm going to bring that slide up again just so we can sort of refer to it. Okay. So this slide is adapted from a couple different places. One is the International Wound Infection Institute, and another place that I adapted it from was from oh no, Gary Sibbald's Nerds and Stonies, which is a wound assessment for infection sort of algorithm that this doctor developed for assessment of infection in chronic wounds specifically. And so this is my standardized approach that I take. There's certainly, unfortunately, there's not a, shall we say, a flow sheet, a standardized flow sheet that is out there and available in Island Health to use. But this is the one that I use and that I sort of recommend, and it works for me. Did you have any questions specifically about what's on this slide?
No, I was just wondering what content can be included. I'm actually new to the CNE role in a long-term care. And in long-term care, we have to be very brief and concise when we educate the nurses there, because the time and everything. So in
course.
nutshell, if I have to educate them, what could be okay, just these 5 points. So example could be, of course, for a localized infection, the sign and symptoms are different. And if it's kind of spreading, the sign and symptoms will be generalized.
Yeah, exactly. And I think, yeah, I mean, here you got some pretty like just bullet points that you could list. And it depends on what your wound assessment flow sheet that you use at your home has. A lot of them have infection built in. If you use point-click care in your home, then they will have signs and symptoms of infection built in. It's just they don't have that differentiation between local infection and spreading infection, unfortunately, right? So that's the key part, is that what wounds can we use our antimicrobial dressings on versus which wounds can we use which wounds are requiring antibiotics. So I'm happy to sort of give you a list by email that you can certainly adapt, or some sort of education that you can use for your nurses. So feel free to send me an email and I can help you out with that after.
Okay, sure. Thank you.
You're welcome.
And then Erin, we've got some questions in the chat as well. So starting,
Oh, sure.
Yeah, with
No, I can't.
Dr. David Clinton Baker is asking, could you please comment on MRSA and whether it needs to be specifically asked for when getting a CNS?
Oh, from my understanding, no. Like, the question is like, does that need to be asked for on the requisition?
I think so. I think that's what he's asking.
Yeah. No, they're always going to test for MRSA, so it does not need to be specifically asked for or requested.
Great. Awesome. And then next we've got Katie Beamish, and she's asking, how do you choose what to clean a wound with?
Oh, that's an excellent question. Well, it depends on what you have available to you. So I think of it as like, in long-term care anyways, 3 categories, right? If you work in community, you might use something different, but in long-term care, we're going to be using either sterile normal saline, commercial wound cleansers that usually come in a spray bottle, and then the third category is antimicrobial cleansers. So for wounds that are have no signs and symptoms of infection and are healable and healing, I go with normal saline or commercial wound cleansers. There's the difference between the two. Commercial wound cleansers include a surfactant in them that is meant to or not meant to. What they do is they break up, we talked about that biofilm, so it will help break up that biofilm that's sitting on the wound bed. Normal saline does not include that surfactant, but that doesn't mean that normal saline doesn't have a place in our practice. If you, like I said, if you have a clean, healing wound, normal saline is good. If you have a wound that's been hanging around a little bit longer and you suspect biofilm, because of course 60 to 90% of our chronic wounds have biofilm, then you can use your wound cleanser. When you can't use your wound cleanser, commercial wound cleanser that come in those spray bottles, is if you have any tunneling in the wound, any undermining in the wound, then you're either going to have to go back to your normal saline, or you can use an antimicrobial cleanser. The ones that we use in Island Health, there's certainly lots out there, but for example, two of the ones that we use in Island Health are Vash and Anicept. Those are both antimicrobial cleansers, and I use those when the wound needs to be cleaned up. So it's got a lot of slough, it's showing signs and symptoms of infection. I did miss one though, actually, sorry, Vash, Anicept, and sometimes we will use iodine as well, because iodine is an antimicrobial cleanser. We only use iodine short term though, but we can use Anicept and Vash or longer term. So that's how I choose what to use when I'm cleaning a wound. It's a big topic, and I do have a webinar on that. So feel free to reach out to me by email, and we can chat more about it, but that's kind of the general principles.
Great, thanks, Erin. And we've got one final question in the chat from Kim Knight. And Kim is asking, could you please comment on the place in therapy for Kenacomb, a combination of neomycin, gramamycin, nystatin, and triamcinolone? You might need to look at them because I'm probably butchering some of the names.
Okay. Kenacomb, I've never heard of this, so it sounds like it's a combination of an antibacterial and antifungal. Yeah, I'm sorry, I can't comment on it. I mean, if it, I don't know. I mean, there are those things that I was talking about earlier where, which is why I don't use antibacterial or antibacterial ointments on wounds. But say you've got that moisture associated skin damage, what's showing signs of bacterial infection and fungal infection, perhaps that could be a place for it, but I don't know the product well enough to really be able to say. Sorry, Kim.
Sorry, so there's two antibiotics in there and an antifungal and a steroid as well. So it's quite a combination. And I was just wondering if there's a role for that, because I'm thinking that it needs a diagnosis as opposed to covering all those bases and, using that for 7 to 14 days.
Right,
but
yeah.
That's okay.
Yeah, I mean, I'm thinking like I imagine that is getting ordered mostly when you have moisture associated skin damage. Maybe you can correct me if I'm wrong. I don't know if that's being ordered around maybe suprapubic catheters perhaps, but yeah, sorry, Kim. I don't have a good answer for you.
All right, Erin, thank you. And we do have one more question that just popped up. Can you speak where to use a syringe tip?
Yeah, so when we're using a syringe tip for irrigating wounds, I assume. Rashi. Okay. So I use, and back to wound cleansing, but I will use a syringe tip for irrigating wounds when I have wounds that are that I want to clean. I know that I can get the irrigation fluid back, I'm cleaning with normal saline generally, so they're clean wounds where I might want to get into a tunnel or into undermining, but I also know that I can get that irrigation fluid back as long as you have the right syringe and tip to give you the right PSI. That's a benefit of irrigating a wound over cleaning a wound with gauze and cleaning solution, is that if you have the right distance from the wound and you have the right supplies, then you know that you're getting the right PSI to clean that wound. Although that has been a topic of some controversy because there was a move towards irrigating wounds maybe a decade or so ago, and this is when chronic wounds started developing. Well, perhaps this is when wounds started developing more biofilm, or maybe this is perhaps when they started recognizing biofilm. When you clean a wound with gauze and solution, sometimes you will get a better clean because you're using that sort of scrubbing motion. However, there are other times when you use gauze and solution where you're getting a less effective clean, and that is because the staff are either very, very gentle and kind, which we know all our staff are, and so they don't want to hurt the resident, or they're a bit nervous, right? They're a bit nervous to put any pressure. So just sort of dabbing at the wound, well, we know that that doesn't really clean a wound effectively. So for a more standardized approach to know that your wound is being cleansed, more adequately, you can irrigate. But you have to have those right supplies. The 30 cc syringe with that 18 gauge irrigation tip. Yeah, and making sure that you can get that fluid back, because that's one danger of irrigating. If you irrigate, of course, and then it sits down in the bottom of that wound, or in the undermining, or in the tunnel, then that wound is just going to keep getting bigger and bigger. Yeah, thanks, Rajni.
Great. Any other final questions for Erin? Great. Okay, well, if there's no other questions, I just want to say a big thank you to Erin. Thank you so much for your knowledge on wound infections, and thank you to all of you for attending. The copy of the slides and the recording of tonight's learning series will be available on the website.